Hello Protrusive and welcome to video 1 of
Sectioning School.
So in this first video and all the videos to follow in Sectioning School, I'm going to show you exactly how I've increased my confidence and competence with extractions over the years by learning how to section just like this. What's different about this video compared to my older videos is I've upgraded the level of quality, and so I can do things like this now. I can actually go ahead and annotate on the screen exactly what I'm doing, and this is going to really add a lot of value to what I'm saying and what I'm explaining. I genuinely want you to learn more from this series of extractions than you did even at dental school. Now, some of the common recurring themes when we're sectioning, like, which burr should I use, which handpiece can I and can't I use, what is the best sectioning technique, which patients are suitable, which aren't. Some of those sort of bigger level things we've covered in the Sectioning School webinar, the launch webinar of Sectioning School. We had that live, and therefore, if you need to revisit that replay again, check out the Protrusive app, it's there. And that will cover like the bigger picture stuff when it comes sectioning. For this video, I'm gonna go specifically talk about this tooth, which is an upper right first molar. We've actually been watching this upper right molar for a while, and I was hesitant to extract it because I really didn't want to. It was a beautiful tooth, and it wasn't really causing the patient that much pain. But as you can see on the mesial root right over here, there is some sort of pathology there, right? We know there's some pathology, and there's lots of inflammation by the gingiva, and actually this is causing a chronic level of pain. The tissues are not happy and the patient's getting bleeding every single day. And the reason why this is happening is I believe that the core used underneath the tooth, underneath the crown, was amalgam. So just in this region, we have some amalgam core that was used, and the crown was finished on an amalgam margin rather than a sound tooth margin. So potentially there's like a biological width invasion here causing for the tissues to be unhappy. And really, I think we're ready for an implant now, and we're not going to go down the whole crown lengthening path, and the patient's accepted it, and I think she will do well with an implant. So some of the things that we covered in the webinar, but I'm just going to just briefly mention why section this tooth in particular. Well, anytime I see a tooth like this, which has got these like nice long roots, which are very divergent, then it's a good idea to section. We want to remove those roots as individual conical roots, because the related problem we have here is that the width of the actual roots themselves is actually wider than the crown. And when you have that kind of scenario, you know it's going to be difficult to bring that tooth out. So whenever you have divergent roots like this, it's a really good idea to section. And also we're quite close to the sinus just up here. And because we're close to the sinus, we want to reduce the stress to the bone, and we don't want to break any buccal plates, because this patient I think will do really well with an implant in the future. So many great reasons to section here, and that's exactly what I did. So let's go through it together. So once I've given my buccal and platal anesthetic, I'm going to check for my anesthesia. So I'm feeling with my probe. I'm actually feeling that sort of deficit, that carious deficit mesially with that amalgam words, that inflammation. I'm then checking all the way around for profound anesthesia. I'm really going for it. I'm pushing. I say to the patient, I'm going to push really firmly. All you should feel is pushing and pressure and nothing else. And this confirms A, if there's adequate anesthetic, and B, the other reason to do this is exactly what Dr. Amir Aliboka said in PDP 166, right? He said that it gives you great information about where you will be luxating and elevating. Where are the elevation points? Where does the probe just sink in? It gives you clues as to where you will luxate first and where you're going to get the most purchase. So two-pronged. Checking for adequate anesthesia and checking for your purchase points for extraction. Now, this tooth had a crown on it, as we know, so I'm going to start off with a diamond burr. And I tell the patient it's going to feel like a filling appointment because you'll be hearing some drilling and whatnot. And I've selected the diamond burr for the porcelain. So diamond for porcelain, and I've cut the porcelain like a little line all the way through, buccal to palatal. I'm now going to switch to my tungsten carbide burr. This is good for metal. So I start by removing the tungsten carbide burr, and usually what I used to do is cut through the entire way, entire buccal, entire occlusal, entire lingual, but I kind of cheated here. I sometimes chance it. So I went all the way buccal, and I think I went all the way occlusal, but not palatal. And I got my Mitchells, and I just started to torque it. You're going to see now a bit of ceramic's going to chip away. But I just really flex it. And sometimes you get lucky, right? After a bit of this sort of torquing movement, the metal flexes, and you actually feel, oh yeah, there we are. That little give there, it's now loose. And then you can literally just take off the crown like that. So sometimes you get lucky. So, why waste time? Okay, so the clue's in the image, but what do you think I do next, right? Should we start just sectioning it into 3 roots at the moment? No, probably not a good idea. Because first, before we start sectioning it into 3 roots, we want to first remove the crown. I want to remove the crown. That's actually probably too much. I'm going to go a little bit lower. I'm hoping I would have cut it a little bit lower. So I want about, 2 to 3 millimeters supragingival cut. This is because if you don't do this sectioning and you try and cut it into 3, you have to drill such a long way to get the trifurcation, right? Now, if you section it at this point, then you just have to drill that much, right? So your burr won't be long enough to even reach the trifurcation area. So you want to actually make your job easier by actually decoronating the tooth. So once you've decoronated it, again, this is something we discussed very recently in that episode with Dr. Alan Mead, right? 5 things we wish you knew at the start of your career. And he also mentioned himself.
I like to flat top teeth. I like to take the crown off before I section too, because you can see deeper in.
Yes, same.
But the thing about it is a lot of times you think, yeah, but there's so much good tooth structure up here. I can grab a hold of them. Like, yeah, except it's too high. So you're more likely to break in a bad spot if you leave that there. So you could argue with me to leave a millimeter or 2 of tooth structure above the gingiva, but not much more than that. If you're sectioning, you'll see better. The tooth is coming out one way or the other. It doesn't matter if it comes out in pieces or a whole piece.
So I'm going to go ahead and show you how I use my diamond burr here to start the decoronating process. So I'm just going distal, mesial to distal, but I'm staying buccal, right? At any point, my burr is not going all the way through the tooth, even though I've got really good protection from the suction, which is really, really important. Your nurse needs to know how to suction well for this, because there we are, a big chunk of tooth, and now we're onto the amalgam. And again, I'm still not going all the way through, because what if the tongue comes in the way, or what if you're working on a lower molar and you're going to risk going through structures? So I decoronated it. I used Luxator to break that last bit of amalgam. I'm now using my Luxator, and the first thing I'm doing is actually I'm just going around, I'm just freeing up some of that gingiva, right? This is really important. It's a habit I've made into doing because I want to prevent having any fractures, any tuberosity fractures. So why is this important? Let's just revise this for a second. I'm going to cast you back to that episode I did with Dr. Chris Waith about tuberosity fractures.
I think one easy thing to do, whether you use a Mitchell's or a flat plastic or something, just push the buccal gingiva off the tooth. Push the distal gingiva off the tooth, push the palatal gingiva off the tooth. And then the logic is, if you hear that dreaded crack, what you want is to have just cracked the bone and not torn all of the soft tissues.
One thing that's really important to do is to kind of release that gingiva, so that if you were to get a tuberosity fracture, you can still sort of stitch things together. If you don't do this and you start getting a tear that goes through the bone and into the gingiva, then you're really, really in a tough pickle. So it's a really, really good thing to do. Just like I did, walk your luxator all the way around and just sort of release that gingiva. So as well as releasing that gingiva, I'm also just getting an idea. Is there any mobility? Is there any sort of nudge within this tooth? Is there any give within this tooth? And this tooth is solid, right? So yeah, definitely a good cold section. So I've selected my burr. I think in this case, I've gone for a tungsten carbide, maybe because it's got metal inside. And one of the rules that we talked about in the webinar is always just start a little bit more mesial than you think. So you're looking at that, but when you look at the occlusal view, see, it's not too mesial after all. So we're starting mesial first, and we're going to go through to separate the buccal roots. Now I'm going to just pause here and show you what the next stages, the next options are basically. So firstly, why do we always start a little bit more mesial? Because when you're like treating the upper right first molar, right, and you're a right-handed dentist, okay, you're always going to be slanting your burr like towards the distal. So whilst it might look very mesial higher up, as you get towards the root, let me actually draw this for you, okay? So let's see, upper right molar. Actually, no, we've decoronated it now, right? So we've decoronated this tooth, right? And let's go here, like so. And now, if I'm starting mesially first, and remember this is the buccal roots, and that's the further back palatal one, the back there, right? So as much as we like to think that our burr goes beautifully down the middle there, it's not going to happen. It's just the angulation is not going to happen. Actually, what really happens is when we're angulating our diamond burr or any burr we're using, is it's going to go at a bit of a slant, like so basically, okay? So therefore, if you start a little bit more on the mesial side, by the time the burr reaches more apical, you're hoping that it's going to be there at that trifurcation area to split all the roots. So whether you're doing wisdom teeth or upper molar extraction, a rule of thumb taught to me by Dr. Neki Jamal is to always start a little bit more mesial than you think. And he recommends about 1 to 2 millimeters mesial. 2 millimeters is a good idea, basically. So if you at the beginning, when you're sectioning, we talked about in the webinar, you're going to cock up few up, and definitely you can reduce that from happening by always starting a little bit more mesially at the most coronal portion. Now the next thing to consider when we're treating an upper molar is it has 3 roots, right? Now we know that we have a mesiobuccal right over here, and we have a distobuccal right next to it like that, and then this is the palatal root over there somewhere. And so what we want to do to section it is we want to go like so, and then the next option is you can either go for a Mercedes sign, right? Because a Mercedes sign, you know, looks like that kind of thing, right? Or we make it into a T like that, basically. So we can either do the Mercedes sign or do a T. Which do I use? I usually use the Mercedes sign, but if ever you end up doing a T, it's okay because it's a valid technique. Lots of oral surgeons do that, and I've been taught both ways. So I tend to actually do more of a Mercedes sign, and that palatal one has more of an angle. So just an idea and for you to experiment. And sometimes you look at the shape and you think, this one might lend itself better to the Mercedes shape or the T shape, and you can decide. But both ways are absolutely valid. I'm using my electric handpiece here, full revs, and I've gone for the Mercedes shape here. And you can see the gutta perca, the amalgam's flowing out, and it actually really guides you, right? And so really important learning point here is how far do you go? Well, a really good thing I was taught is you need to go far enough until you see some bleeding, because until you see some bleeding, right, you're not through. You're just not through. So what I mean here, so obviously you should be using some sort of magnification, but around about here, right, you should be seeing where you've done your section, you should be seeing, like if you look really closely, you should see some blood coming. And if you're seeing some blood coming, that means, okay, we're through to the bone. So here's another way to explain it, right? Let's say you start sectioning a tooth, right? And I've used black here to section, and you get to about here, and you don't actually reach that furcation, which I've colored in red, right? And so you'll know because you won't see any bleeding, right? The problem with this is that when you then later introduce an instrument to try and split it, you're not 100% in control which way it's going to sort of start cracking. Will it crack this way? Will it crack more that way? And so a really good technique that has helped me, I think, is if I try and get my section all the way to bleeding, all the way through the tooth to the bone, then I know I've got a nice clean section. I've got this and this completely independent. Now, do you need to be careful of the sinus? Well, yes, you do, but have a look here. The sinus here is way up there, and the trifurcation where those three roots sort of split together is more around about there. So we have a margin of safety, but you got to look at a tooth. If the sinus is really like, pneumatized, it's lower down, then we might then choose not to do a clean section in that kind of a scenario. So I'm now going to be accessing the distal part, the distobuccal part, and you've got a nice clean section developing. And then now I'm going to start using luxating. I'm just luxating, and I'm seeing what moves, okay? I'm seeing, is there any movement? Will the mesiobuccal go first? Will the distobuccal? I see a little bit of movement of palatal there. And oh, there we are. It's the distobuccal that's showing me movement. So that's the one I'm going to focus on. For me, there's no hard and fast rule about go for this root first. Whichever one seems to be the one that's moving, I'm going to take that one out first. Can you notice my thumb and my finger? I'm supporting the palatal and buccal bony wall. So I don't want any pressure on that. I don't want any flex on that. So I'm just supporting it. Now that I've felt some movement on the distobuccal, I'm going to go in with my root forceps, and I'm not doing any sort of crazy movements. I'm just wiggling, a little bit wiggle, and I'm just going to gently remove it here now. There we go, success. And then, they really start falling like dominoes, right? So now that you got the distobuccal out, the other one's gonna come out easier. Except in this case, it didn't. This is actually a really tough extraction. These roots were not budging too much. I get a bit of movement of mesiobuccal. There we are. We're getting good movement there. But, the palatal was not budging at all. So what can we do at this point? Okay, so I keep working it, and I think I'll need to do something. Have a look at the contact point of that molar against the second molar. And anytime you're stuck, you can actually use this technique anytime, basically, to just remove the contact. Once you remove the contact, it becomes much, much easier. And actually, this is a top tip for any extraction. If you're struggling, if you cut through the contacts, i.e. break the contacts like you would do for a crown prep, it becomes much easier. Okay, now that we're getting a lot more movement, it's time for the forceps. Okay, so we're going to get the root forceps on, and I'm not going to do any crazy movements. I don't want to snap off the coronal part. I'm just doing little twisty movements, and at this point I'm going to pause. So why have I got my handpiece out again? Okay, if I find that it's going to take too much force or it's just not budging, and usually the rule of 6, okay, so rule of 6 for me. If I'm doing something for 6 seconds, right, and nothing is changing, I'm going to think, okay, how can I do things? How can I change an instrument? Can I change my angle? Can I change my forceps or whatever? And so if something's not budging, I'm going to change something about it. So I'm actually going to go back and remove some bone, okay? Which bone am I removing? I am removing the interfurcal bone, okay? I am not touching the buccal bone. I am not touching the palatal bone. In this case, I'm not touching the mesial and distal. That's not as precious as the buccal and palatal, but I'm actually working with the interfurcal bone. So So what's the interfurcal bone? Well, let me show you actually towards the end. Okay, so I've actually skipped all the way to the end. So yeah, spoiler alert. Yeah, we took the tooth out at the end. But what is the interfurcal bone? Well, let's just label everything. Okay, so we have buccal down here. You've got palatal up there. So I don't remove those. So where the distobuccal root is, I'm just going to put a circle on that. Probably shouldn't have used a black pen. Sorry, guys. Mesiobuccal and then palatal. These are the sockets, right? So the interfurcal bone is all that bone in the middle areas, in the channels, basically. That is the bone that you can sacrifice if you need to. But remember, we don't touch the buccal, we don't touch the palatal. We try and stay away from the interproximals, although sometimes you may need to. But it's the interfurcal bone in the middle that we can remove. And that's exactly what I was doing there. So let's go back to that point. Okay, so this is me removing some of that interfurcal bone that's sort of hanging on to that palatal root. So remove the bit of bone. It's not too apical, it's rather coronal actually where I removed it. And now you can see a bit more budge, right? You've got a bit more budge, a bit more movement, and I'll probably feel a bit more confident with my forceps that nothing's going to snap. While I'm here, I'm also working a little bit more. Get more mobility from that mesiobuccal root. So I'm just luxating. As you can see, I'm very impatient. I'm moving from one thing to another thing. 6 seconds I spend on it. I'm going to get my root forceps. Am I getting enough movement within the first 6 seconds that's made me confident? Yes, I am. So because enough movement, that's lovely. There we are. There comes a palatal. And so there was just one left, which is the mesiobuccal. So at this point, again, I'm going to try and luxate, try and sort of get some elevation point. Still not budging, and it's been 6 seconds, and I'm thinking, what can I do now? How can I change the game now? Let me try with forceps. Okay, so let me try some forceps. Let me try some twisting. 6 seconds are gone, and still it's not coming out. So hey, guess what? I'm going to remove some furcal bone. I'm going to remove some annoying furcal bone that's hanging on. That's still going to heal very nicely. It's not going to affect the future implant. And there we are. I'm going to remove some bone, and hopefully I get a bit more mobility, a bit more give from that tooth. So you just work on it a little bit more. If nothing's happening and sick, change your instrument, get a wider, thicker elevator, change my approach angle, find a purchase point that's giving me lots of movement. Okay, I'm feeling lots of movement there now, so that's good, that's encouraging, supporting the premolar in front of it, and then let's give it a go. Yeah, lovely, that's gonna come out, lovely. Oh, joy, look at that curve, that's a curvy one. Righto, and then really, really important, right? If there's any sort of, broken bits of bone and whatnot, you want to get your Mitchell's trimmer, the spoon end of a Mitchell's, and scrape away. Now, this one didn't have like a chronic abscess or anything. It was just that sort of mesiobuccal inflammation and that PDL inflammation. So I'm not expecting an abscess, I'm not expecting any pus, and there wasn't. But I'm just kind of checking, are there any dehiscences that have been created? Are there any fenestrations kind of thing? And look how clean that looks, right? It looks really, really clean. There is no debris there, and so this will heal well. So I just finished up scraping up the buccal and palatal walls into proximal. It's good to remove the biofilm on the adjacent teeth. And now I'm going to get those hema sponges, right? Those little collagen sponges. I'm not squeezing it, I'm leaving it in kind of full form. So let's remember, guys, about the recent episode, again, with Dr. Amir Alibokis, where he mentioned...
Please don't squeeze the sponge and stick it into the socket, because the whole point is you want that space in the sponge for the blood to imbibe and fill. And a lot of people squeeze these sponges and shove them into the root sockets, and then it's not doing anything. It's just it's just sitting there, and it'll just fall out eventually. So, like you just said, cut them into shape and put sponge in each socket, or if you have a large socket, 1 or 2 sponges without squeezing them. Just gently place them into the socket.
And so the final one, we're going to place this collagen bit of sponge in that distobuccal root. And this one, for me, it didn't need a suture, right? If you suture it, comment below, let me know. But it didn't need a suture. The gums were well approximated, and we get to do an autopsy, if you like, of the curvy roots. There we are. I'm so glad I sectioned this one. Now, this curve that we have here, it might not seem like very banana rootish, it might not seem very extreme, but with someone with hard, dense bone without periodontal disease, that can be a tough cookie to remove. So we need to respect the fact that we've got curves in molars, and if it's got a curve, like I'm going to section a lot anyway, and my threshold for sectioning is very low, but if it's got a curved root, you bet I'm going to section. So always at the end of the extraction, I like to just study the roots. Sometimes the patients want to see them, sometimes they don't, but that was a good extraction. I'm happy that we managed to preserve a lot of bone, and that the implant in the future will probably not need any grafting, because this was a traumatic. Now, comment below if you think you do anything differently today, or any other tips or any questions you have at all, basically. Remember, I'm not an oral surgeon, but I've done a hell of a lot of sectioning, elevating in the last few years, and I'm just kind of sharing what I do. It doesn't mean I'm always the best or right in the way that I do it, and I'm always learning from you guys as part of the community. So thanks so much for making it all the way to the end of this video. Now, for those of you on YouTube watching this, please do hit subscribe and the like button if you enjoyed this, but do also consider joining our Protrusive Premium app. It's got videos just like this one, and it's got VertiPrep for plonkers, the rubber dam isolation case library with 30 plus clinical rubber dam videos, other extractions and crown fits and onlay fits and all that kind of good stuff that you like. It doesn't really break the bank, and it helps Protrusive continue to do what we're doing. It's a big team behind the scenes to keep this all going, especially the podcast. So thank you all for your support, but also I truly believe that what we're doing is very different to other educators, and we will never stop making dentistry tangible for you. Thanks again for watching all the way to the end.